Welcome back, everyone, and good morning. We are here at Circuit World in Blue Ridge. It is now time for Ask the Doc with Dr. William Whaley. How are you doing this morning, Doc?
Great. I'm doing great, Lauren. And yourself?
I'm doing just fine. I can't complain. We want to thank Georgia Cancer Research Center affiliated with Northside Hospital for this segment. You ready for the first question, Dr. Whaley?
No, I'm not.
You're not?
No. First of all, we got to talk about why we're here. As you said, weather got us here.
That's
you have to. What do you got to have, Josh? You got to have your rain report, right? Yep. So last week I told you that we were 1/100th of an inch below normal for the year. Everybody says it's rained so much. So where are we now, Josh? Are we above or below?
I'd say we're barely above.
We're below by 2 inches. So now, not that I hope it's going to rain 2 inches, because I got grandkids from New York coming in tonight. But so it's okay that we're here. And now the second thing is, what about the tie?
Yes, tell everyone.
Why am I not wearing my? Well, I was going to wear my flag tie, because this is the Apollo 50th anniversary, and they're going to land on the moon tomorrow, 50 years ago. But one of your expert panel members who's close to me, who believes we didn't land on the moon, I figured it'd be rubbing her nose in it if I wore my flag tie. So I'm not wearing my flag tie today. I'm wearing my gender acceptability tie. And why would I be doing that, Josh? Send her back. Okay. So, well, you can talk to the expert panel about send her back. And
I know about send her back.
Yeah, okay. So that's why I'm wearing this tie. I'm in deference to my president, who may have stepped on his you-know-what by being genderly inappropriate there on his tweet. So I'll shut up, and you can do that with the expert panel. Go. All right. We're ready to talk about. We're going to talk about lung cancer today, right?
Breast cancer.
Oh my goodness. Okay, go.
Yes. So our first question is, I survived breast cancer, but my treatment left my fingers and toes permanently numb. Is there anything I can do to reverse this, or that can be done about this?
All right. So it sounds like a pretty straightforward question, but it leaves out several important factors. One, did this patient not take chemotherapy? Doesn't say. Second, it doesn't say how long ago they ended the treatment if it contained chemotherapy. And then it gives it the time frame of it's permanent. Well, I mean, you don't know what's permanent until you get to the end, right? All right, so let's get that first. First, we're going to define it, all right? I know you love my pictures.
I do. I enjoy the pictures.
Okay, right. So first thing they got to do is they got to tell us how long out from chemotherapy they are. 6 weeks, 6 years. There's a huge difference in time. And secondly, did they or did they not really take chemotherapy, which they don't really say. And they indicate that it's still fingers and toes. So you're going to learn something here in just a minute. So right. This is you got that picture of that ugly looking foot up there? All right. So this is the thing you see on TV and the ads, where they show the guy walking on the glass, and they tell you, ask your doctor to give you a prescription for Lyrica or something like that. Interestingly enough, 107 million people in the United States have peripheral neuropathy. Now that is not, they haven't all had breast cancer, have they?
I would assume.
No, I would assume not. Okay. And they have not, they have not all had chemotherapy. So the incidence of peripheral neuropathy is high, and you have to separate out in every patient that's got it, how much of this is actually related to diabetes, nutrition, prior alcohol, age or something, and how much of it is related to treatment they may have received. Now, I'm not going to get into all the rest of this stuff, but if you get to the definition, you've got to have this burning, stinging thing lasting at least 20 minutes at a pop, and let's go up to the next one that's got that whole body on there. All right, so now, peripheral neuropathy, if it's chemotherapy related, generally is going to have other things that you're going to notice happen along with it. So if chemotherapy made your hair fall out, that's the top, made your fingernails turn brown, well, you know, that's more likely to have been related to chemotherapy.
Right.
If you have weakness or any sort of motor nerve damage, it's not really peripheral neuropathy. It's something else. And if you're having cramps in muscles and so forth, it's not peripheral neuropathy, it's something else. The last one says fasciculations. If your muscles are twitching and twitching, it's not peripheral neuropathy, it's something else. So, all right, let's go to that little one about the peripheral neuropathy causes, and then we'll get into some fun things here where people suddenly discover how complicated the issue really is. All right, this next one, causes of peripheral neuropathy. As you go down through these things here, the drugs, chemotherapeutic drugs, are way down here at the bottom. You've got diabetes, renal disease, hypothyroidism, alcoholism, work-related exposure to heavy metals and so forth, and inflammatory diseases like lupus and rheumatoid arthritis and all that sort of stuff, and even vitamin deficiencies, which in our country are rare, before you get to chemotherapy. Now, taking all of that into account, we're going to then go put this back. So now that's peripheral neuropathy in the globe. We're going to take this back, and we're going to get that one that says the diagnostic criteria for it to be related to chemotherapy. First, you got to have a time-related feature of I gave chemotherapy, and then these symptoms began. Not I had symptoms that chemotherapy may have made worse.
Got it.
All right. Second, the distribution of the discomfort needs to be symmetrical, and it needs to be in the distribution of gloves or socks, not way up here and down here skip areas. Okay, so it's going to start at the very end. It's going to work its way up. It's going to start in the hands first, because the distance that nerve runs is shorter than the distance this nerve runs down to your toes, right?
Right.
All right, this patient says it's still in fingers and toes. And generally when you stop chemotherapy is really given for 3 to 6 months. Stop the chemotherapy, then it sort of rapidly begins to get better, and then the hands get better before the feet get better. So anyway, so that we've come to a sort of a time frame. If I give you your first dose of chemotherapy today, you're not supposed to start getting peripheral neuropathy until you're out here where you've had 3, 4, 5, 6 or so months of chemotherapy before you begin to get the symptoms. All right. Now this last one's a 3-page long thing. People will never be able to see it all, but I put it up there just to show there are 3 pages of single-space typewritten characteristics of peripheral neuropathic findings with different chemotherapeutic drugs and diseases that risk from really kind of high. That's lung cancer treatment with the drugs cisplatin and carboplatin. That's not breast cancer. Down some of the drugs we use in colon cancer, that again is way up here. And the breast cancer drugs are kind of down the list. So we don't really think of this as being a big time occurrence in breast cancer unless they are getting the drug Taxol.
Right.
Now, if they're getting the drug Taxol, they've got pretty much cancer, and you have to take the hazard-benefit ratio of giving them that drug and its chances that it's going to reverse the cancer versus the chances that they're going to have a little bit of numbness at the tips of their fingers and the tips of their toes. So we always measure the benefit versus the hazard of everything we give. All right?
Of course.
Now, there's a hazard to taking an aspirin, right? You can get a bellyache. If your headache's bad enough, you'll get in your car and drive to 7-Eleven and buy aspirin and take them and take the risk because the headache's so bad. So you've sort of made your own hazard-benefit ratio judgment. So you're not going to get Taxol unless you've got locally advanced or recurrent cancer of the breast, and you need to pardon my French, kick you know what and take names to get rid of the malignancy. So you have to sort of look at this in hazard benefit ratio. Next I'm going to show something. How do you define it? This is a cute little tool here. What you're seeing there is kind of like it's called a monofilament. Just imagine you've got a sort of a stiff piece of fishing cord or a stiff piece of plastic that you've got at the end of an instrument, and then you take that thing and you push it on the bottom of the toe or the bottom of the finger, and you see how much it bends. Then you know the more it bends, the more pressure you got on it, and that is when do you feel this thing actually touch you, okay? Now you're going to close. I want you to close your eyes. I want you to take your hands and turn them upside down like this on your, just like that. Now, so I want you to imagine I've got myself a feather here. Okay. And I walk up and I say, if I touch you, you tell me where I touched you, okay?
Okay. On the tips of my fingers. On like the top.
Okay, right. So I mean that's sort of a rough approximation of what we do.
Right.
Back in the day, before we had the modern types of chemotherapy, your mama's too young to remember that the first real set of chemotherapeutic drugs that we used for cancer were Hodgkin's disease. And one of the crucial drugs in that recipe that was necessary to cure you of Hodgkin's disease, which had a 100% fatality rate, was a drug called vincristine. And that drug, we used to measure the degree of peripheral neuropathy with vincristine by having you take a piece of paper and hold it between your third and fourth fingers like that. Now, if it fell to the ground like that, you know, as you could not hold it between those two fingers, then you were beginning to get peripheral neuropathy. By today's standards, we never have any peripheral neuropathy that gets to the point where you have motor weakness. As I said earlier, it's just it's all sensory stuff. So the degree of peripheral neuropathy that we're having with our chemotherapy today is like way down here, and people are complaining about it when it used to be way up there. They were real grateful for it because it was curing their disease. Are you with me a little bit?
Yes.
All right. So here's what I ask my patients. Were you able to button your shirt, zip up your clothing? Can you cut your meat and eat? Then that's the hands, okay?
Right, the fine motor.
Yeah, I mean, if you're able to do that, yes, you've got peripheral neuropathy. Your hands are numb, and it will most likely get better. Now, the question said, this is permanent. Well, what it means is, from the time I ended my treatment, I've still got it.
Right.
Well, that we didn't get is that 6 weeks, 6 months, or 6 years,
yes,
right?
Yes.
Okay, so generally by 2 years, this has disappeared to the point where they might have a little bit of numbness in the toes. I have a few patients who have had to have repeated treatments for gastrointestinal cancer over years using the drug oxaliplatin, which has saved their lives because it's been in their liver and their lung. And they have been off treatment for 2 or 3 years, and they say, Doc, my feet still hurt, but I'm still working as a lumberjack. I mean, my feet hurt. So that's sort of the idea. You know, some things you're gonna have to learn to live with.
That risk benefits ratio.
Yeah, hazard benefit ratio.
Higher.
Okay, now what can we do for it? And unfortunately, there's not one thing in this world that's ever been proven to prevent it. So there's not anything we can do before we start the treatment that will make it not occur. As I mentioned way back, vitamin deficiencies. So whey can be cause peripheral neuropathy unrelated to chemotherapy.
Right.
So way back when we were talking about vincristine chemotherapy, none of these drugs that I'm getting ready to talk about existed. So we gave people vitamin B6, pyridoxine, in a dose that would be as high as this roof when you go down to the drugstore to buy a supplement, it would be down in there. I mean, a big dose of vitamin B6.
Wow.
And we gave it with great enthusiasm. Now, I'm not convinced it really helped much, but we still do it. So we give people vitamin B6, and we tell them vitamin B6 cannot hurt you. You can't get too much vitamin B6, and it may help you. So if you look at this last one, let me have the one that says treatment. Interestingly enough, we've talked about almost everything that we've ever had before in here. Muscle contraction, tension, headaches, inflammatory bowel disease. So now we're going to talk about peripheral neuropathy. And the very first thing you've got on there is...
Antidepressants.
I be doggone.
I was trying to say the first word. I
Well,
was like,
well, you don't need to have that one. You just need antidepressants. Now,
yes.
we treat headaches with that, right?
Right.
We treat chronic pain of any sort with that. We treat gastrointestinal complaints with that. So antidepressants of all types. The next 4 lines there are just different types of antidepressants. Well,
Okay.
All right, now the next one is non-steroidal anti-inflammatory agents, NSAIDs. You remember that? So before anybody talks about narcotics, there they are, back on the Advil and the Motrin and whatever those other things are cost. And then some of the fancier medications that work in a vitamin way. And lastly, you get into this class of drugs that we know now because kids like to take them and steal them from their parents, where they have been given anticonvulsant type drugs, Neurontin. A lot of people get because they have chronic headache or whatever, and then the kids like to take them out of their mama's medicine cabinet and sneak a couple of those. So we have a bunch of things we can do in terms of medication. None of the medication is like taking 2 aspirin and your headache goes away, your fever goes away. And the best treatment I tell people is tincture of time. Keep tearing pages off the calendar. Be as active as you can. Avoid pain medicine as much as you can. Take some pain medicine if you need it. But the number of people who need pain medicine is very, 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 very small. So I would tell the person who asked this question, if you had a breast cancer bad enough to require Taxol, which would have been the drug that gave you some peripheral neuropathy, then your cancer had a high risk of recurrence, and the fact that it hasn't recurred is a small price to pay for peripheral neuropathy. Or it had recurred, and if you're still alive to answer the question, then the drug did what was asked of it. And lastly, can you make anything to do it better? I said, yeah, keep tearing pages off the calendar and then let your doctor give you one of those drugs if he thinks that it might help you. All right, got that?
You got it. Thank you for
All
that
right.
explanation, Dr. Whaley. A lot of stuff there, and it's, when you explain it, it just sounds so simple. And I'm like, okay, I'm not, when it came time for me to choose a career path, I told my parents, I said, well, doctor is off the table. But I enjoy this segment because you explain this stuff.
Well, funny enough, my wife says when you ask me what time it is, I tell you how to build a watch. And she's not saying that as a compliment. So anyway, go ahead.
All right. Well, don't forget, everyone, if you have a question for the doc, send it into info@fetchyournews.com and put it in the subject line, Ask the Doc. Again, we want to thank Georgia Cancer Research Center, affiliated with Northside Hospital, for this segment. You ready for the second question?
Sure enough. This is good. This is going to remind you of your grandmother. Maybe at your age, it'll be your great-grandmother. So go ahead. This is going to be a good question.
All right. Our second question today is, are skin tags harmful? Skin tags are a common condition, but what do they mean for your health?
Well, for your health, they really don't mean a thing. But for your quality of life, I guess, and you would be a great example of this, much better than BKP.
Oh my.
Because skin tags can grow anywhere. So we're going to pull up that first one. Where do skin tags grow? Well, skin tags, if they grow underneath your arms, right, or on your torso somewhere underneath that thing, you might be seeing them. But what if it's on your eyelids? What if it's on your neck?
Right.
What if it's on your face? All right, now that's not adverse to your health, is it? But it's adverse to the way you look
Right.
and the way people perceive you. And I've got some ugly pictures. I'm not going to show any ugly pictures. I'm just going to show a relatively common type of skin tag. Now,
Oh my.
that's a skin tag. It
But
kind
it's
of
really, really zoomed in.
yeah, it's zoomed in.
Okay.
It's zoomed in, but this skin tag's probably about that big.
Got it.
All right, now that can be here on you. Could be underneath it wouldn't very likely be up on the face. It would be underneath your chin, but that ain't going to look good as you get ready to come do your TV program, is it?
Right. No, it's not.
All right, so it's not harmful in the least. Now, there are some type of skin tags called neurofibromas that can be associated with an internal disease, neurofibromatosis, and that can be associated with seizures and stuff, but it's kind of easy for a physician to tell the difference. So now you got that ugly thing on you. So since I said this is a good question, it's going to make you think of your grandmother, quite obviously, if you do not have any economic disincentive, right? If you don't live on the dark side of the moon and you got that thing on there and it's ugly, you're going to go to the doctor, right?
Right,
You're going to
right.
go see your family doc who can take care of this, or if it's up there on your face, they might send you to the dermatologist. So now we're going to talk about what this kind of like what the question opens up for us is. BKP and many on your expert panel, I just saw some come in, like what they call,
Natural remedies.
got the natural remedies up there? All right, so now here on the left-hand side is kind of one of the ugly ones. Like, matter of fact, it looks exactly like the one we just got through with.
Yes, it
All
does.
right, okay. Now, this says this one would usually be on the neck, armpits, underarms, around the eyes, breasts, or groins. All right? Now, here are 7 natural ingredients that are proven to help eliminate skin tags. And you got garlic and aspirin and other stuff. So
Some
this
household
is natural stuff. But the way that works is it takes a long time.
Really?
Yeah, you put the stuff on there day after day after day after day, and you cover it with a Band-Aid, and then it begins to macerate, and then it gets down there and it sort of falls off. But it probably leaves the bottom down there, turns right back around and regrows.
Oh no.
But my first bit of advice is go back to your family doc, the dermatologist, let them take it off, or if you want to do something else, you can go to your pharmacist and say, what do you have that applied to this skin tag would make it go away? And you know, they got all sorts of wart remover, don't they?
Right,
Okay,
yes.
and they've got this acne stuff all the women put on the face all the time. What was that called? Retin-A. You know, everybody your age and older goes and gets Retin-A in a compound, puts it on there. That's supposed to keep them getting wrinkles. So there are over-the-counter preparations that have been marketed in the last decade or two that have irritants in them, generally that's supposed to make your wrinkles go away, that your pharmacist could give you to rub on there. Then once again, you'd have to rub it on there for weeks before it would go away. So that's sort of it's not going to cost me a doctor visit. But this is in deference to your grandmother now. Put the next one up, because this is the way when I was a kid that all skin tags were treated.
Oh my, that looks.
Now, what are they doing there?
It looks like they're tying a string around it, and they're.
That is a piece of fishing cord that your grandmother ties around the skin tag and pulls tight. Okay?
Okay.
And tomorrow, she pulls it a little tighter.
That sounds so.
No, it's not. It's really painless. And tomorrow, she pulls it a little tighter. And so you go to visit your grandmother for the week, and you've got 8 skin tags on you, and you come home and you got no skin tags on you, and you haven't been to the plastic surgeon, you haven't been to the doctor, and nobody's injected you with Novocaine and snipped it off with a pair of snippers and then put something on there to make a blood clot. Grandmama got it with a piece of string. So, I don't know who wrote the question, But at the end of the day, the answer to the question is skin tags are not harmful to your health. They are very disconcerting when they are in a location that causes you to have embarrassment because of where they are.
Right.
They're very easy to be removed by your family practitioner or a dermatologist or whatever under most circumstances. But just to get to the fun thing in the mountains, there are less than medical ways to do it, and grandmother's old way with a string is if it is. It has to have skin tag. Then has to have a sort of a bulbous thing to it, and if it comes straight out like a mountain, your skin tag will work. But the other things that make it go away are better. Okay.
So in another way, just go see grandma.
Go see grandma.
Go see grandma.
As a matter of fact,
grandma will take care
as
of
a matter of fact, your expert panel is going to be absent a member today, who's on the way to the airport to pick up the grandkids.
Is she?
Who are coming up here to be with grandma. How about that?
Oh, great.
But I hope
great.
they don't bring any skin tags with them. So.
I hope not either.
All right, go ahead.
Or else we know what she'll be doing, right? All right. Well, this time, Dr. Whaley, you always like to share with us some news that's going on in the medical world. So what do you have for us today?
All right. Well, I punched off the top few of them, and I brought this up first last week before it got to the big news, but it got to the big news a couple of days ago, and that is that we have had rapidly rising drug overdose deaths in this country for the last 5 to 7 years. The drug that we have, I think, Rick, did you fund getting the narcotic Narcan available for all the first responders? Were you one of the people that?
No.
Okay. Well, anyway, Narcan now is the.
All the time.
Huh?
He uses it all the time.
He uses it all the time. Well, Narcan, the reverse a drug overdose drug that we used to have in the emergency room, and physicians, when we had black bags, we carried in our black bag, is now available to everybody in the general public.
Okay.
And so when you have a family member who has a narcotic issue and gets arrested by the police for buying or selling or whatever, that's a stimulus now where social workers and stuff tell you to go get yourself a dose of Narcan to keep at home. So if your husband or son or somebody overdoses, you can whack him with it at home and save their life.
Oh my goodness.
On the front page of today's business section, it announces that Delta Airlines is now going to have Narcan on their planes in the first aid kit so that flight attendants can use it in flight. Now, you don't usually think much about people having drug overdoses on their way home to see their mother or going on vacation.
That's what I was just thinking.
Well, there are dozens of those every year. People have died on there. There have been 2 recent ones, not important what airlines, where there were EMTs or first responders on the plane. They were able to breathe for the patient until they could get the plane to the ground, and then EMTs ran on the plane and gave them Narcan. So anyway, the number one thing in the medical news today is overdose deaths fall for the first time in decades, and that's
good news.
That's good news. And so part of it is how strict it's gotten now on writing narcotic prescriptions. I mean, you can't get a narcotic prescription now without getting your thumbprint and a pint of blood taken and everything else. And the other is the wide availability of the Narcan. Now this, I hate to do this, but just every week there's something else. So if you just look at these, if you look at the next 2, this one is an E. coli outbreak due to ground bison. So that's the buffalo burger, you know, everybody's all get the buffalo burger. Huge out, and this, every nut and berry eater I know who wears macrame and sandals and natural foods and all that stuff eats this stuff. What's that stuff called? Now, all right. I'm just saying. All right. I'm not trying to. I can't eat it. I can eat it. But those grandkids that are on the way to Atlanta right now live in Manhattan,
So they love
And
the
they're
hummus.
they're big time yuppies, and they got hummus, and they bring it up with
With the veggie sticks and eat.
well, wait a minute, veggie sticks and stuff. When they bring it out for Granddaddy when we're at the beach or something, they bring me some tortilla chips to eat it with.
Oh,
So
yeah.
at least it's a little bit like you were eating salsa with something. But anyhow, so these two products that you would think about sort of in the healthy industry, you would think about the buffalo burger
Right.
as being more
An
meat,
alternative
more meat, less fat.
Right.
You think about the hummus, I'm not going to eat the guacamole and chips. I'm going to have hummus with a carrot. So these two things that are supposed to be healthy are contaminated. The hummus has got listeria in it, and then the bison has got E. coli in it. And it always makes me feel good to be able to laugh at the folks who are trying to tell us burger eaters how to live, and you're trying to hurt yourself. So I think that's enough news for the day.
Yeah, well, I mean,
And flu season is going to start soon, and last year's vaccine, the expert panel told me, it's only 28% effective. I said, well, if it saved 28 lives for every 100 people get it, that's fine. But they tell me that this new flu vaccine, of course they told me this last year, it didn't turn out to be true, is going to be much more effective. So you'll hear that beginning in August, and this is mid-July. So we'll start.
It's gonna be real soon.
We'll start hyping the flu vaccine pretty soon.
Well, good deal. Always glad to hear that there's something better
All
to
right.
fight against the flu. So thank you, Dr. Whaley. Thank you for being here. Of course, everyone, you can share our Ask the Doc segments on our YouTube page. It is Fetch Your News, FYN TV, and look for the playlist Ask the Doc. This segment is brought to you by Georgia Cancer Research Center, affiliated with Northside Hospital. Dr. Whaley?
We
always
did it.
Good to have you.
We did it in the rain, right?
That's right. We braved the storm, and we came out, and we had the...
And we need 2 inches
had
of
the
rain to
show.
catch up.
There
All
we
right,
go.
Lauren.
Well,
Thank you
maybe
very
we'll
much.
get it.
And I hope, BKP, that things are going well for you and your family, and we miss you.
Yes, we do. BKP will be back next week, though, so don't y'all worry.
All right.
But when we return, it will be time for the All-Star Political Panel, so don't go anywhere. Good things are coming.